Well, when I was at school, I got very concerned about the impact that humans were having on the natural environment, and so I decided to go and train to be an environmental scientist. And while I was taking my undergraduate degree, I studied something called human ecology, which is very similar to what we would call population science. And I very much enjoyed that aspect of my undergraduate degree. And I also got quite interested in human health at that time, so I decided to go and study at the London School of Hygiene and Tropical Medicine as a postgraduate. And I did a master's and a PhD there. And I was there at a very lucky time. I was taught by people like Jeffrey Rose and Michael Marmot, and I had Valerie Beryl as my PhD supervisor. And as you can imagine, that was all very inspiring. And so I decided at that point that I really wanted to pursue a career in research. So after a long career, it's quite difficult to pick just one piece of work that I'm most proud of. So if I may be a little greedy and highlight two pieces of work. The first happened quite early in my career. I mentioned doing my PhD at the London School of Hygiene and Tropical Medicine, and that was on perinatal mortality and home births. And as a consequence of that, I got involved in the debate around where women should give birth, because at that time the prevailing orthodoxy was that the safest place for all women to give birth was in a hospital under the care of a consultant obstetrician. And with Alison McFarlane, the National Perinatal Epidemiology Unit, we wrote a book called Where to Be Born, in which we analysed policy on place of birth and then set out the evidence to examine whether that was in support of or not of the policy. And we came to what was at that time quite a controversial conclusion, which was that the evidence didn't support the policy of all women giving birth under the care of a consultant obstetrician in hospital, and that therefore women should be given an informed choice about where to have their babies. And there was a lot of debate about that issue at that time, and there was a parliamentary select committee to which we gave evidence, and eventually the policy in the 1980s around place of birth was changed to give all women a choice about where to have their babies, and that's something that still obtains today. So women today have a choice about whether they can have their baby at home or in a midwife-led unit or in a hospital under the care of an obstetrician. So I'm proud of that in the sense that I think we did make a contribution to the debate, and particularly a contribution about looking at the evidence as you're evolving policy. And the second thing I'm proud of is work that I did with Lawrence Moore, developing, robustly evaluating and now implementing a peer-led smoking prevention intervention for adolescents. And that intervention is being implemented in Wales and in parts of England, and is just beginning to be implemented in Scotland. And in the main trial paper that we published in the Lancet on that evaluating that intervention, we estimated that if implemented on a UK-wide basis, ASSIST could prevent up to 40,000 young people from smoking. And I guess I'm proud of that, because that seems like a worthwhile thing to have developed and be implementing. Well, I think of the many serious challenges that we face in public health, looking to the future, I think climate change is the greatest challenge that we face. And although I'm an eternal optimist, it does sadden me to think that I was taught about the greenhouse effect over 40 years ago, and we've had pretty compelling evidence for many years now about climate change. And it saddens me to think that both at a local, a national and an international level, our action on climate change still falls woefully below the mark, because clearly it presents an enormous challenge to human health and well-being on a global scale. Yes, so the acronym DECIPHer stands for Developing and Evaluating Complex interventions for public health improvement, and it's a collaboration between the universities of Cardiff, Bristol and Swansea, and we particularly focus our research on children and young people. We have 4 programmes of work within DECIPHer, one focused on schools as a setting for health promotion, one on multiple risk behaviours, one on randomised controls and other research methods for evaluating public health interventions, and one which is linked to the new DECIPHer Centre, which is part of the FAR Institute, which is concerned with using anonymised, routinely linked databases as a tool for evaluating public health interventions. I think as a unit we're probably best known for conducting large-scale cluster randomised controlled trials with good process evaluations embedded in those, so that we can not only answer the question as to whether an intervention is effective and cost-effective or not, but that we can also look at questions around for whom it works best and under what circumstances, and why it works or doesn't work. We in DECIPHer try to work very closely with policy and practice, and we have an increasing number of people who work both based in DECIPHer, in academia some of the time, but also work in public health practice, and I think that's a very valuable way to work. We also try hard not to do research on young people, but to do research with young people, and we have a very active public involvement group of young people. They chose for themselves the name Alpha, which stands for Advice Leading to Public Health Advance, and they advise us on all aspects of the research that we do and have a fantastic input into our work. I'm not sure I feel the evidence is yet strong enough to be able to suggest just one thing that I would really want to invest in. I suppose there's a number of points that it is worth making about multiple risk behaviour. I think the first is that actually for young people it's perfectly normal to engage in more than one risk behaviour during adolescence. But the research that particularly we've been doing in DECIPHer seems to show that beyond that, every additional risk behaviour that you engage in quite substantially increases the risk of an adverse health outcome, even quite early on. So even at 18, there is a quite substantially increased risk in things like depression and anxiety and harmful alcohol consumption. As to what we do in terms of reducing the number of risk behaviours or preventing the number of risk behaviours, I think there's a lot of people now who are beginning to think that rather than taking the approach which we've done in past years of tackling risk behaviours singly, addressing smoking or alcohol or physical inactivity, we should tackle these things multiply. And it's understandable why people might think that that's the more rational thing to do, given that these behaviours co-occur. But I think we need to understand a bit more about whether, in fact, tackling these things multiply is the most cost-effective approach before we go wholesale down that route. Children and young people spend a lot of time at school. School is also a workplace, and for many families their lives are very much structured around children attending school, and that of course then presents fantastic opportunities for health promotion. We also know of course that children need to be healthy if they're going to learn, and equally that if they have a good education that will protect them and they will enjoy better health during their life course. So it can be a real win-win. However, I think, as public health researchers, we've always got to be mindful of the fact that the primary purpose of schools is to educate. And I say that because a systematic review, a Cochrane systematic review of the Health Promoting Schools programme that we have conducted recently within DECIPHer showed us that in the large number of trials that we included in that review, very few of the researchers had collected outcome measures concerned with education, so things like school attendance or educational attainment. And that was surprising because those data are generally routinely available, and disappointing because I think if we want to persuade those working in education that they should also be devoting some of their resources to promoting health and making their schools as healthy as possible, we've got to demonstrate to them that as well as improving children's health, it's also going to improve their educational attainment and attendance. I think my sense of it is that they can be, but there are obviously some pitfalls. I've certainly been impressed by the way that over recent years some people in public life have talked very openly about their own experiences of mental ill health, and have also used that as an opportunity to argue for better research, better treatment and better services for those with mental illness, and it seems to me that that's been a very positive thing. Well, I think I would always have wanted to have a career which involved investigation, and I would have quite liked to have pursued a career in television and been a documentary filmmaker, but that would have meant I would have been behind the camera and not in front of it as I am now, and I think I would have been much more comfortable there.